Thank you.
Yes, we've been joined now by Assemblyman Ra.
Assemblywoman Malliotakis.
Thank you, Commissioner, for being here today. I wanted to follow up on the spousal refusal questions that were asked earlier today. It's my understanding that as the law exists, the healthy spouse can keep the family home, a car, and assets of about $113,000. Is that correct? And if it's eliminated, what would the assets go down to?
So I think there's two proposals. There's the eliminate that ability for a spouse to basically declare I am no longer supporting my spouse and therefore my assets are basically not looked at for the purposes of determining my spouse's Medicaid eligibility. There's another proposal in the budget that does address the amount of assets that an individual can have, and what it does is it does basically adopt a floor, that's a federal floor, that in essence is designed to help ensure that, once again, like spousal support, it's a similar proposal in the sense that it's designed to try to help ensure that the individuals who are accessing the Medicaid program are ones who really need it the most. And if there's a way for families to be able to help pay for some of those costs before they enroll in Medicaid, that we attempt to ensure that is done to the maximum possible. I would say about that proposal is that there are certain assets that are actually excluded from the calculation, so they would not be impacted by this change. So for instance, the family home up to a value of $850,000 of equity would not be affected. Car, certain types of retirement funds would not be exempted or are exempt from those calculations. So we think at the end of the day, the policy is a fair one.
In previous proposals, the floor would go down to like $20,000 in assets. Is that not what's being proposed this year?
I'm trying to think. In this particular one, I'm not sure whether we've proposed it or not. I'd have to go back and look to see whether we've proposed it in previous years. But it's we have proposed in previous years various variations on the same theme, which is, in essence, tightening up the eligibility rules in long-term care to try to make sure that the programs being accessed, as I said, is the people who need it the most. What I would say is that with the baby boom generation getting closer and closer to the long-term care system, I think we just have to collectively, if you look into the future 5-10 years from now, and the people who will be sitting in this room at that point, they will be grappling with, or we will be grappling with, the long-term care portion of the program growing at a rate that I fear will put tremendous strain on the New York State budget. And that's why I think what we're trying to say now is that while any of these individual initiatives don't generate a lot of incremental savings immediately, the potential for cost avoidance down the line is quite substantial.
The total savings of this would only be about $10 million, right?
Right. So there's multiple initiatives, and that's why I say that the individual ones in the given fiscal year are not that large. I mean, every incremental savings is helpful because it helps to cover some other costs in the program. But you are right that on the generally speaking, the proposals don't generate a lot of in-year savings. But I do think if you think about it over the next 10, maybe even 20 years, they could be quite substantial.
See, I as someone who represents many seniors, I think this is really the wrong approach in terms of trying to cut and achieve savings. You're talking about 8,400 people that are senior citizens that are very vulnerable, and truly to tell them that they need to get rid of all their assets to care for their spouse, I don't think that's the approach that the state of New York should be taking, especially when we have about 6.5 million people. We're talking about 8,400. It's a very small population. So I would urge the governor and the administration to reconsider that. It's even more concerning when we're talking about this $10 million when we see that there's a budgeted $38 million that would go, that's set aside here in this budget, and also in last year's budget, by the way, although I don't think it has been spent because of the federal lawsuit that's currently being reviewed by the Supreme Court. But with the President Obama's executive order, the state is now given the burden to provide $38 million to provide Medicaid for the amnesty executive order. Is that correct?
So that was an estimate from last year in terms of what we expected the potential cost to be. I think it was an out-year estimate or the second-year estimate off the top of my head. But yes, that the executive order signed by the president basically would have expanded access to Medicaid to additional, in essence, normally non-qualifying immigrants for Medicaid.
Why are they non-qualifying?
So under federal law, you can be here legally in the United States, but be non-qualifying for Medicaid. Usually that's because you are in some sort of a status of you're waiting for some number of years. I think it's like 5 years before you can sign up for programs. And so when that executive order was signed, we had to anticipate what the global cap impact was. That said, it has not gone into effect. So at the moment, there has not yet been a cost associated with it.
So 100% of that burden, though, is being pushed onto the states, right? Because the federal government does not allow these individuals to qualify for Medicaid. Is that correct?
Yes, I'm thinking is that we're unique in that way, in the sense that it's unique in the sense that under our state constitution, if you are a legally resident individual, even if you're non-qualifying, we had a court decision, called the Aliesa court decision, which basically says that you are entitled to the same treatment as any other qualifying, any other person who's here legally. So that's a uniqueness, and that's because of the New York State Constitution, okay. Whereas other states, you are basically governed by the federal law in terms of Medicaid eligibility.
Okay, thank you. Moving on to heroin, I share the concerns that my colleague brought up earlier, and I've read a lot about the commissioner and your efforts to bring Narcan training throughout the state and putting it in schools and putting it in prisons as well as pharmacies, making it more available for individuals. I think it's certainly a tool in the toolbox and something that, but it should be a last resort, right? We should really be more proactive in trying to stop people from using it to begin with and becoming addicted than waiting until they're almost dead to then come with a solution. So I was just wondering, the state a couple of years ago passed legislation regarding PSAs, which I've seen a couple, and I think they're very good, but also requiring education in schools. What has been the Department of Health's role specifically in doing more proactive outreach and education?
Well, we are working on this issue with programs with the community, working with the counties on this, and we are also, we've tied this into our prevention agenda as well to tackle drug addiction in general and to try to decrease the amount of opioid use. I hear your concerns. As a physician, I recognize this, and I've seen too many patients come in who've overdosed on narcotics and the dangers there. So, and I concur that this is an issue of education. As we move forward with the transformation that we're moving in healthcare, again, we are moving into communities and away from hospitals, and this will be some of the ways that we can tackle this problem as well. I have reached out to all the physicians in the state about this issue as well, and will continue to do so and bring it up. And I brought it up at some of the associations which deal with this issue, particularly anesthesiologists.
Okay. I want to just shift to inspections of facilities here in the state of New York. In 2014, it was found that only 8 of 25 clinics that perform abortions in the state had not been inspected in 12 years. Subsequent to that, I filed a FOIL request with your agency to try to get the information on inspections of facilities that conduct any type of medical procedures. It took from March 25th was when I initially filed. They told me it was going to come back on June 9th. Didn't get it, and then they postponed it again to September. Finally, I had to almost threaten a lawsuit, and December 7th, they did give me the information. I wanted to talk a little bit about the staffing and why it took so long to get those numbers from me. It just seems like it's information that should be readily available. I mean, shouldn't the state know, when their facilities are being inspected and what the results were?
We can get you the issues on the numbers. I will say that all of our family planning grants do follow the Title 10, the federal law, Title 10 from the federal law on that. But the specific numbers I can get to you.
But does the state have already a database in place keeping track of when facilities are inspected and what the results of those inspections were? Because it's, 6 months to put together this type of information just seems like an awfully long time. It just seems like you should have that readily available, and I was wondering if you do or not.
We'll find out what the date. We do track all the information. We'll see what we can get for you.
As part of the results that I got back, I found that 11 facilities in our state haven't received inspections in over 10 years, including one that hasn't been, it's a eye surgery center in Brooklyn, which I represent, that hasn't been inspected since 1987. And so I'm quite curious about the facilities in this state and if we're paying the proper attention. So what is your criteria in terms of inspection? Because I know the law itself, which I'm looking to have changed, doesn't require a set, every 1 year, every 2 years, like you have tanning salons and pizzerias. We don't inspect our health facilities within a time frame, and I find that to be troublesome. What are your thoughts?
Well, we follow, as I mentioned, we follow what the criteria set forth by, federal rules are, and we also clearly always want to make sure we provide the best care, and we do the inspections as necessary.
Just shifting to Medicaid, because I know I ran out of time. I just want to make a point. It won't be a question. But basically, my concern is that we're shifting Medicaid to the city, $651 million burden over the next 3 years. Can you tell us what the rationale is for that?
Well, the $630 million will. One key thing is that this is still more than last year, and the city will have about $185 million savings. I believe.
Yeah, so I think the rationale, as I said, was that we thought that the proposal was balanced in the sense that state is picking up a considerable amount of additional costs and has each and every year as a result of the program under the global cap. And the idea was that the city, which is where more than 50% of the total costs are incurred, and obviously to a significant benefit to the city, that there was some rationale for an increased contribution there, phased in over time. To allow the city to be able to adjust, but obviously we're more than prepared to work with the legislature, work with the city to see if there are alternatives to that.
Okay, thank you.
Thank you, Senator.
Thank you, Assemblyman. We've been joined by Senator Sue Serino.
And also Senator Ruth Hassel-Thompson.
Our next Senate speaker on the list is Senator Diane Savino.
Thank you, Senator Young. Thank you, Commissioner. I want to go back to the minimum wage. I'd say it's fair to say that when the governor announced in December that he was going to lead the campaign to raise the minimum wage to a livable wage where a family could live in dignity, some of us were thrilled and some of us here less so. But all of us expected that at some point in his budget documents we would see funding for the employees that the state is either directly or indirectly responsible for compensating. So to say that we were somewhat concerned when the budget came out in the health budget and in the human service budget, the agencies that are directly contracted by the state to provide either home care or developmentally disabled care, human service care, there is no allocation for them to be able to pay that minimum wage. Now, I know you mentioned in your earlier comments, Jason, that when we did the Home Care Worker Parity Act of 2011, when it was originally enacted, there was no funding there for it. And in fact, 3 years later, the agencies came forward and they expressed how difficult it was for them to meet that. And as a result of that, in the 2014 budget, we included another $300 million. So I'm concerned that we think that somehow we're going to have a different outcome this time. So how are these agencies supposed to pay it? And at the end of the day, assume we do adopt the $15 minimum wage in the budget, and we don't provide the funding for home care agencies so that home care workers are actually compensated appropriately. What kind of a message would we be sending as a state that it makes more sense to deliver pizzas for a living than to take care of the elderly or the sick?
So we will during the budget negotiation process, we will work through this and will clearly be part of the discussion. And as I mentioned, it is a phased on, the governor has this as a phased in period. So, and I recognize some of the concerns that you have about this, but we will work this through during the process.
It's a huge concern, Commissioner. And so we will be watching, particularly as the 30-day amendments come out, to see that there is funding there to take care of that. So I want to jump back to an issue that Assemblywoman Malliotakis raised about spousal refusal. As you said, every year for 26 years, this issue is included in every budget, and every year for 26 years, the legislature bats it right back out. But what I'm concerned about is in the 26 years that we've been playing this tennis game with this issue, what efforts has the state taken to encourage the insurance industry to create an affordable long-term care plan? Because many people would buy it. They cannot afford it. And in fact, earlier this year, many people who did wisely purchase long-term care when it was affordable to them received a notice that their premiums are rising more than 70%. So what can we do to prevent that from happening, and so that patients and families can purchase a long-term care plan that they will then be able to use to take the burden off of Medicaid?
Well, I think there's two parts. One of this is the issue of education and about long-term care. And I think that as we move forward with our efforts to tackle the issues of long-term care, and as Jason mentioned, population's aging, and we need to address that, I think it does involve getting the message out to all of those about the benefits of doing it. That's one part. I cannot answer about the 26 years, but be happy to get some more information.
And if I could add something too, another initiative that has come out of the last couple of years is the launch of New York Connects on a statewide basis. These are aging and disability resource centers that are now open in every county in the state of New York. And what those are is a location where individuals and families can go when they have either themselves or a loved one who now is starting to need some help at home. And one of the benefits there is that they provide advice, counsel, connection to services and you don't have to be on Medicaid to access those services, whether that's Meals on Wheels or any one of a number of things that communities have available. Because one of the things we do know is that providing some of those low-cost services to individuals earlier on, not waiting for them to get to a situation where because of how their apartment is set up or because of some other issue that it leads to a fall and leads to the need for to get on Medicaid because you need extended home care services or you need other types of services that we can get into more of even a prevention mode. I think that's one of the benefits that those centers are going to be able to offer is really counseling, support, and access to services that, as I say, are far more affordable for individuals and families that really hopefully can help ensure that people are living safely at home and not needing to go through the process of divesting themselves of assets in order to access the Medicaid program.
Well, there's no doubt that those are worthy considerations, but I want to repeat again, we should be using the power of the state to force the insurance industry to create an affordable product for people. That would be the real answer for many families if they could afford. By the time you think about long-term care, it's too late and you can't afford it. We need to rethink this. I want to go back to a question based on your testimony about the safety net hospitals. So there's no doubt that 5 years ago when the MRT was originally put together, the HHC really did not have an equal seat at the table. And as a result of it, they have not really been treated, in their estimation, they've not been treated as fairly. And I'm sure we're going to hear from Dr. Ramshew later on today about they have some proposals on reorganization of the HHC. But one of the problems that they face is, the safety net system for New York City, is they have the disproportionate share of uninsured patients, and they don't get the same Medicaid reimbursement rate that other hospitals do, the better situated providers. So is there anything in this budget that's going to change the way the HHC is reimbursed?
So in terms of their HHC and their role in MRT, I would say that on the Medicaid redesign team was Linda Gibbs, who was the deputy mayor under Mayor Bloomberg for health. And so I believe they were represented and were active parts, and the city supported the MRT recommendations back in 2011, which is now like ancient history now.
Say that was then, this is now.
Yep. So, but what I would say is that in terms of the Health and Hospital Corp of New York City, obviously we are, and we work very hard to assist them with cash flow issues on what seems like daily basis. We know about some of the financial challenges that they face. In fact, we are working with them on ideas about how we might be able to convert some funds that are at risk There were called UPL payments, to convert those perhaps to another use, to maybe to give them sustainability well into the future, to maybe even allow for some growth in those dollars. We require a further amendment to our waiver, but we're working on a proposal with them on that. I think one of the challenges is that we have is that, at least in our discussions with the federal government, they've been making it very difficult for us to get a federal approval for those payments. And the reason is that they have questioned whether or not we're paying HHC too much. And whether or not there's sufficient cost information to suggest that it's appropriate. Now, we disagree with that approach, but that's been a back and forth issue for the last several years with them. And but at the same time, we absolutely agree that they are essential. We need to help them in their strategy. I'm very hopeful that some of their strategies around the exchange and the use of Metro Plus and is going to grow and diversify the people who utilize the system. I think they provide excellent quality of care and are the biggest Medicaid provider we have in the state, so we are absolutely committed to doing everything we can to help ensure their sustainability.
Great. And finally, I want to go back to the opioid crisis. One of the questions I have is what we're seeing now, obviously with the heroin abuse problem, is people are showing up in the emergency room in crisis. And they're stabilized, and then they are sent home with a recommendation to go to an outpatient treatment program, largely because our treatment protocols, I believe, and I'm sure some of you believe, are somewhat outdated. The idea that you only need an inpatient detox for alcohol or benzodiazepams sends these people back out into the street. And once you have a person in a place where they need help, that's the best time to get them engaged in treatment. So what can the state do to begin to have a discussion with the treatment providers and even the insurance companies to change the treatment protocols to deal with this crisis?
So, well, one part of this is the issue of getting those who come into those facilities into a primary care setting and tying their behavioral health issues, if there are related to that, for opioid, with primary care. That will help move them forward and not have them end up coming back in a second time and a third time after that. I think that's the first part. This is part of what our whole agenda is with the advanced primary care model. Specifically, your question is in insurance and coverage. Is that?
Well, yes, because the way people are sent back out into the street. So again, you come into the emergency room, you have overdosed on oxy, heroin, whatever the case may be. It doesn't require an inpatient detox, so they stabilize you, and then they send you home and refer you to a primary care doctor if you don't have one. They refer you to an outpatient treatment program, and then they leave it up to an individual who is addicted and incapable of making rational decisions about their care. We all know that. So the question is, why not change the protocol so that we would require a 28-day inpatient detox or rehab to stabilize them and begin to put them on the path for treatment, instead of doing this over and over.
I hear what you're saying. So the question is, why not bring them into the hospital or have them in there? I mean, there is obviously cost associated with that. And what we need to do is strengthen the outpatient component to this, I believe. And I think that if we bring them in and we get the right people there to help them put into the right system and to follow up and to use whatever kinds of programs we have in place and telemedicines, or have social workers and others go out there to make sure that they come back in, that would be helpful. I mean, I recognize that you say, well, once you have them in the hospital, wouldn't it be easier just to get all those services there at that point in time? But I think there's a way to do this as an outpatient as well, assuming that they are safe to go to leave.
I mean, this is my final comment. I understand the cost concern, but there's an equal cost to repeat admissions to the emergency room, ambulance, calls. So I'm not sure we're really saving money. And, having worked in my previous career with people who were addicted, it is very difficult to get people to come into treatment and stay there if you send them home and expect them to be able to handle their addiction. It just doesn't happen that way. So I just think it's something that we should begin to look at, and I hope that the Department of Health will help us develop that policy. Thank you.
We will.
Thank you. Assemblyman McDonald.
I agree.
pretty much discussing all the things we may not like or are concerned about, but there are a lot of great things that are going on. And obviously, it's a very large department, large budget. You know, the New York Connects program you mentioned is, I can tell you as a practicing pharmacist, has been an excellent resource to help patients get the care, because we have a lot of things going on in the community setting out there. And I'm going to touch on a couple different areas of interest. I will probably get into drugs at some point, as you would guess. But there's a proposal about a pilot project for retail clinics, which, let's face it, they've been out there and they've been kind of working on their own in some aspects. But what I was interested in is how do you account for the $5 million in savings that's attributed to it? I kind of see that as really an opportunity to actually provide more care, which I think is going to possibly increase costs for providing good care. But how are we accounting for savings in that aspect?
Sure. So the retail clinics, these limited service clinics, we feel will be beneficial to those who will utilize them for several reasons. One, we feel that this will tie individuals, we'll make sure when they come in there, it will be tied back to their primary care provider. We recognize there have been some concerns about the retail clinics in caring for those who are under the age of 2, so we are not going to have that as a case. We want to be sure those individuals are tied to the pediatrician. We will make sure these retail clinics are in areas of the state where there is no other access or limited access to care, so that is a definite advantage to this. And we will also ask that the retail clinics are tied into the SHINE, the State Health Information Network, so that the information can get back to their primary care doctors or to others, and it will help improve our SHINE as we move forward on that program. So I think that this is a way to provide accessible care, and I would like to see the next steps of where we will be with that.
Good. Moving on to opioids. I know we've all been talking about this. Now, I was glad to see an expansion of the maximum of 4 opioid prescriptions per month. I think it's to the managed care environment. Not taking a lot of savings, which is fine. It really gets to the larger issue, which is overuse and repeated use. Recently, and I think I reached out to the department about this about 2 weeks ago, some reports were out there in regards to opioid overdoses in the actual, coming in the ER, they're being brought back to life, they're being released back, and in 90% of the cases, these individuals are being given opioids again by the prescriber, because the prescriber has no idea that they had an overdose. And my original thought was, the PMP, let's expand the PMP, and the message back was that would require a total overhaul of the PMP. And I'm sensitive to that, I understand that. But I would just suggest, this is not really, I don't want to make this a full debate, but that between the RIOs and all the information we have there, and the fact that prescribers truly are abiding, in most instances by the PMP, that we find a way for the Department of Health, using all the privacy options we have, to get that information back. It seems illogical to me that individual who almost died, that we spent a tremendous amount of resources on to bring them back to life, to have them go right back to the prescriber and not have the prescriber take that opportunity to say, wait a minute, we got to take a time out, we need to move you into treatment. It doesn't make sense to me.
I hear you, and I think that you're right, that there should be some red flag that goes up to the prescriber regarding this, and we will look into this, and I recognize what the potential privacy issues that are involved, and we have to tackle that, but we've tackled those kind of problems before, and we will look at what can and cannot be done through the ISTOP program as well.
Okay. Moving on to the profit cap on the health plans, and it talks about reducing the profit cap from 5% to 3.5%. So I guess the question I would probably surmise is that the plans are very profitable under the Medicaid managed care plan, or is it they're making too much money? Or I don't hear that from the CEOs that I deal with, but I'm just kind of curious. I'm not a shill for the plans. I'm just trying to understand it.
Sure. So that, which is an initiative that helps generate some savings within the confines of the global cap, comes out of actually an OSC recommendation from a previous OSC audit, which suggested that there were certain plans that, for-profit plans that had generated fairly substantial profits, and that there would be some benefit to the taxpayer if we restricted the profit capacity from 5% to 3.5%. And so we take those OSC audits very seriously, and you'd see there's a couple of other initiatives that are directly out of the OSC audit recommendations that we're proposing to implement. So it obviously doesn't, if you don't make a profit, it does not impact you, right? It's so as a result. But there were a couple of plans, a couple of fairly large plans that generated in the last year a decent-sized profit, and therefore this basically would have restricted those profits. But yeah, that's the core of the proposal.
So it's across the board, whether it's for-profit or non-profit?
It only applies to the for-profits.
Only for-profit. Thank you. Good. Moving into the drug arena for just my last couple of questions. The specialty drug. You have an accounting for about $1.8 million in savings, I think. Is that the number? Is that?
That's yes. I could look for it, but that's about right.
So that therefore you've kind of earmarked some drugs, whether it's 3 drugs or 300 drugs, that fall into that category, correct?
Correct. So as I said, we had an access to information from one of the pharmacy benefit managers relative to prices that was being paid in pharmacies here in New York State. On behalf of Medicaid managed care plans. And so basically what that savings is identify some particular drugs where both in fee-for-service, which obviously is a much smaller portion of the business now, but also a thought that we could extrapolate that result onto the remainder of the managed care plans, that we could generate what is a modest incremental savings as associated with simply getting the lowest price possible for those particular drugs.
I think you mentioned to Member Rhea that you have a list, or you'll be able to provide a list of what those drugs are. I too would like to get a copy of that list if possible. I think I'm concerned, there's no such thing as a specialty drug. If you look for definitions, you won't find them. You won't find them in the education department. So, there is a concern in the community, and I say the community as the pharmacy community, but I also mean the patient community, that what defines a specialty drug? Is it because it costs $300 or it costs $500? And then we get into that whole discussion, which you're all intimately familiar with, which is access issues. And then we get into limited, and it's something that I'll be continuing to monitor and pester you about as we go through the process. Because at the same token, you're absolutely right, the state should get the best price possible per unit for medication. But along your lines, Dr. Zucker, appropriate use of medication and making sure that the right patient gets the medication and it's used properly is really what we all should be working for. In regards to generic pricing, you mentioned, I think there's a $26 million savings. Is that attributed to the NADAC pricing that's supposed to be effective May 1st, or is it sounded like you're putting a limit in on what the generic price would be, which concerns me only for if that's the case. The concern is there's been a lot of erratic behavior going on in the generic drug market. Mm-hmm. I can tell you as a pharmacy provider, and I can also say as a state legislator, we're all suffering with that. What I don't know is if you just put a limit in, like the SMAC list, which when been challenged has not been successful for pharmacy, are we going to be creating another problem where we're creating access issues for our patients, or is it the savings accounted to the NADAC price scheme?
So the proposal, and there is a proposal both for blockbuster brand name medications as well as for the generic prices, and you had mentioned erratic behavior. I would say that some of the behavior is more nefarious than just simply being erratic, and there's been obviously quite a bit of coverage of some of that problematic behavior. In terms of, for a long time, generics, if anything, prices would go down, and we've actually seen some pretty substantial increases in some high volume generics in the not too recent past. And so basically the proposal is that gives basically the commissioner the ability to impose, in essence, a cap on price increases in generics, cap tied to the CPIU or CPI urban inflation index. That can be adjusted if there are reasonable circumstances for which would justify such a cap, or so if there's something like a lack of supply or a major supplier ceased to production or something to that effect. But the idea is that this would none of the burden for the collection of and making sure that we were keeping those prices would fall on the pharmacy. It would actually be a direct requirement on the manufacturer to rebate the state in order to ensure that price ceiling is not breached. So as a result, I don't think the pharmacists should have any fear from that policy.
Well, thank